Welcome to the Hospital Medicine Unplugged podcast. This is where we really try to take a deep, evidence-based dive into some of those complex inpatient topics that challenge us daily. We want to make sure we're not just, treating symptoms, but really getting to the specific etiologies.
And today, the focus is on esophagitis.
Yeah.
It sounds simple, right? Inflammation of the esophagus.
Yeah.
But in the acute care setting, it forces us to navigate this surprisingly broad and clinically really crucial differential diagnosis. So our focus is specifically on optimizing how we diagnose and manage it in our hospitalized patients.
Yeah, exactly. We define esophagitis, broadly as that inflammation of the esophageal mucosa. And like you said, our first thought, our clinical intuition, it almost always defaults to acid reflux, to GRD. But I think the hospitalist's real job, well, it starts the moment we move past that initial assumption.
Right.
We have to consider that whole triad of potential causes. You've got eosinophilic infiltration, you have medication-induced injury, and then, critically important for our often immunocompromised patients, infectious causes.
And it's not some rare thing we hardly ever see. It's actually an incredibly frequent finding on endoscopy for inpatients. If you look at data, studies looking at hospitalized patients referred for upper GI esophagogastroduodenoscopy, EGD, show this really startling prevalence. It's around 33%.
A third. Wow.
Yeah, basically 1 in 3 patients who get scoped has some degree of mucosal inflammation in the esophagus.
That 1/3 prevalence, that's a huge clinical load. And, we should probably clarify, the esophagitis itself isn't usually the direct cause of death, right? But its presence, it is highly associated with higher short-term mortality, which almost certainly reflects, the significant burden of underlying comorbidity these patients carry. Things like advanced heart disease, kidney disease, cancer. So the esophagitis, in that context, it kind of functions more as a marker of systemic vulnerability.
That's a crucial point, that stratification. But we also have to admit, we sometimes actively contribute to the risk in the hospital setting itself. We introduce these key, sometimes avoidable hospital-specific risk factors.
Like what?
Well, foremost among them, I'd say, is the use of wide-bore nasogastric intubation. And also just the requirement sometimes for prolonged supine positioning. Those two things kind of conspire to increase mechanical trauma and really maximize the exposure time to refluxing.
Okay, so that immediately begs the question then. If we're talking prevention, which is often, easier than treatment, what's the single highest yield thing we can do, maybe standardize, for patients who need tube feeding?
It's pretty straightforward, actually. It's prioritizing fine-bore nasogastric tubes over the wide-bore ones, specifically for enteral feeding. Now look, wide-bore tubes are absolutely necessary sometimes for gastric decompression, right? But once enteral feeding is the goal, we should really make that immediate transition to the fine-bore tubes.
Why the fine bore specifically?
Because they dramatically reduce that mechanical friction and the local tissue trauma. And that trauma contributes heavily to the inflammatory changes we see in the esophagus.
Got it. So, okay, our mission today then is really to move past just, say, empirical treatment. We need to synthesize the latest guidelines, ACG, ASGE, along with DSA guidance for the infectious side of things, to make sure we land on the accurate etiologic diagnosis first, and then apply truly tailored evidence-based therapy.
Exactly. It requires starting with that recognition that in pretty much every case, we have to look beyond just reflux.
That's the etiologic imperative, as you said.
Yeah.
So the first major hurdle, I think, is just acknowledging that diagnosing this based on symptoms alone, it's notoriously unreliable. The typical symptoms people present with odynophagia, that's painful swallowing, dysphagia, which is difficulty swallowing, and retrosternal chest pain. There's just massive overlap with peptic ulcer disease, functional gut disorders, even primary esophageal motility issues.
Totally agree. You just can't hang your hat on symptoms alone to guide treatment. Now, sure, reflux, esophagitis, GRD, it definitely remains the dominant cause. And it presents with those classic symptoms, the heartburn, the regurgitation, we all know those. But clinically, we've got to be vigilant because severe erosive disease can progress, sometimes rapidly, to upper GI bleeding. That might show up as hematemesis or melena.
And that's where the grading system comes in, right? The Los Angeles classification.
Exactly. It's essential. It gives us a standardized, objective way to grade the severity. It ranges from grade A, which is just small breaks confined to the mucosal folds, all the way up to grade D. Grade D is circumferential breaks involving at least 75% of the esophagus. And that grading really dictates the intensity and duration of our PPI therapy afterwards.
Okay, so moving beyond the kind of obvious GERD, we hit eosinophilic esophagitis, or EOE. This one's different. It's a chronic immune-mediated condition defined by that eosinophilic infiltration into the esophageal epithelium. And for us as hospitalists, this is crucial to keep in the differential, especially, in maybe younger adults with a history of allergies, asthma, rhinitis who might get admitted for related issues.
Yeah, and their presentation is often quite distinct from typical acid reflux. While GERD usually causes that burning pain, EOE primarily causes mechanical problems. So adults typically present with chronic chest pain, but not cardiac, dysphagia, and frequently recurrent food impaction.
Oh, the food impaction. That's often the trigger for the EGD, isn't it?
It often is. It leads to an emergent scope, and that's frequently how we make the diagnosis. In kids, it's a bit less specific, maybe chronic feeding difficulties or vomiting that just won't quit. The key mechanism, though, is that chronic inflammation leads to this subepithelial fibrosis, maybe stricture formation, making it progressively harder for food to pass.
Okay, then there's that critical bucket for our hospitalized, often quite vulnerable patients, infectious esophagitis. This diagnosis has to be absolutely top of mind for any immunocompromised host, whether that's due to HIV, cancer treatment, high-dose steroids, you name it.
Right, and we generally deal with three main culprits here. First, Candida albicans. It's the most common, and endoscopically, it gives you those classic whitish kind of adherent plaques. You can almost scrape them off. Second, herpes simplex virus, or HSV. That typically causes smaller, scattered, sort of punched-out ulcerations. And third, cytomegalovirus, CMV. That one tends to cause larger, maybe solitary, deeper linear or ovoid ulcers, often down in the distal esophagus.
And the symptoms for infectious.
Often characterized by really severe odonophagia, painful swallowing. Sometimes it's so bad the patient literally refuses to swallow their own saliva. It's intensely painful.
Wow. Okay, another key inpatient cause, and one we can maybe do something about, prevent or mitigate, is medication-induced esophagitis. This sounds like a combination of mechanical and chemical injury. Patients usually present with this acute onset odynophagia and retrosternal pain, and it's temporally related, right? It happens right after taking a specific pill, maybe the night before admission or shortly after they get here.
Yeah, and we absolutely must know the key offenders because they're medications we use constantly. The high-risk classes include bisphosphonates, things like alendronate, NSAIDs, NSAIDs, iron supplements, potassium chloride pills, and tetracyclines, like doxycycline.
Doxycycline, interesting.
Yeah, the mechanism is pretty straightforward. It's direct local mucosal injury if the pill just lodges in the esophagus and dissolves there instead of making it to the stomach.
Which highlights where our role shifts a bit, even during the acute stay, towards prevention counseling. It sounds almost too simple, but we have to explicitly stress taking these high-risk pills with a good amount of water, like at least 4 ounces, a full glass. And then, crucially, staying upright, sitting, or standing for at least 30 minutes after taking it.
Yeah, that's not just, common sense advice. It's a vital intervention. It helps ensure the pill actually clears the esophagus before it starts to dissolve and cause that local burn.
Right. Okay, finally, there's that hospital-specific nuance you mentioned, especially in the critically ill, mechanically ventilated patients. Even if we're giving aggressive PPI therapy, the mucosal injury can persist. Why is that?
It's because the pathology down there is often multifactorial in the ICU setting. We see something called duodenogastroesophageal reflux. That means bile and pancreatic secretions are refluxing all the way up. And this alkaline reflux, it's highly toxic to the esophageal mucosa. It complicates the picture even when we're suppressing acid effectively. Plus, you still have that constant mechanical irritation from the endotracheal tube or the NG tube itself.
Okay, that complexity really makes it clear why just empirical treatment has its limits. We need a clear diagnostic algorithm, and it sounds like it often needs to bypass simple pH monitoring and go straight to visualization and, importantly, getting tissue.
Precisely. Endoscopy, the EGD, it becomes mandatory, not really optional, for patients who present with those alarm symptoms. So things like persistent dysphagia, unexplained weight loss, obvious GI bleeding, or new iron deficiency anemia. And additionally, anyone whose symptoms are truly refractory, meaning they don't respond to a robust, say, 4 to 8 week trial of high-dose PPI therapy, they absolutely warrant an EGD.
And the EGD lets you see directly, which is indispensable for grading severity using that Los Angeles classification we talked about. And crucially, it lets us rule out complications, Barrett's esophagus, malignancy, deep strictures. But we need to be clear, just looking often isn't enough. right? Targeted biopsy is the key to telling apart those non-GERD causes.
Absolutely. Let's focus on the biopsy protocol itself, because this is where, honestly, clinicians sometimes fall short,
Man.
especially when thinking about EOE. According to the current AGA guidelines, to really maximize your diagnostic yield for EOE, you must get at least 3 to 4 biopsies from both the distal and the proximal esophagus.
Both, not just one area.
Right. A single biopsy just isn't enough because that eosinophilic infiltration could be really patchy. You might miss it.
Okay, but here's the clinical dilemma, the one that hits us right in the inpatient setting. The diagnostic gold standard, ideally, requires withholding PPIs for maybe 2 to 4 weeks before the biopsy. That's often needed to distinguish true EOE from something called PPI-responsive esophageal eosinophilia, or PPI-REE, which looks the same clinically and histologically, but it responds fully to acid suppression.
Yeah, and holding PPIs for 4 weeks in an acutely symptomatic inpatient. That's often just unethical or completely impractical. So our inpatient diagnostic approach has to shift a bit. If the patient has severe symptoms and they fail a high-dose PPI trial while in the hospital, we have to act on the biopsy findings we get then and there. If that eosinophil count meets the threshold, typically it's over 15 eosinophils per high-power field, even despite the acid suppression. That pushes us towards initiating topical steroid therapy right away, rather than waiting weeks for that ideal, maybe outpatient diagnostic confirmation.
That's a really practical point for hospitalists. Okay, turning now to the infectious workup. Guidance from IDSA and ASM seems clear. We need both brushings and biopsies.
That's right. For Candida esophagitis, the diagnosis is often pretty quick. You can use fungal microscopy on the brushings using potassium hydroxide, KOH, or chalcofluor white stain. That confirms the presence of pseudohyphae. But you still need to correlate it with the histopathology from the biopsies.
Okay, and for viral causes, does it differ?
It does, slightly. For HSV, which tends to be a more superficial infection, histopathology showing those classic signs, ballooning degeneration, intranuclear inclusions, is reliable. But nucleic acid amplification testing, NAT, on brushings or biopsies is actually highly sensitive and usually HASTR. Now, crucially for CMV, the infection is deeper. It often involves the submucosal blood vessels. Therefore, the diagnosis relies almost entirely on histopathology from deep biopsies, looking for those large, classic Cowdery type A intranuclear inclusions.
Deep biopsies for CMV.
We got it. And we really have to stress this. Viral culture for CMV has poor utility here. It's explicitly not recommended for the diagnostic workup of CMV esophagitis. Just stick to the biopsy.
Okay, so we've scoped, we've biopsied, but what about that really tough case? The patient whose EGD is maybe non-diagnostic or whose symptoms just persist despite optimized PPIs and maybe targeted EOE or infectious therapy. This suggests the problem isn't just acid or tissue inflammation. Maybe it's something mechanical or functional.
Exactly. This is when we have to bring in the adjunctive diagnostics. Ambulatory pH monitoring, or even better, impedance pH monitoring, guided by the Lyon consensus criteria. That's reserved for objectively assessing reflux. If symptoms persist, we need to know, is the acid exposure time truly excessive?
Yeah.
Or is it perhaps non-acid reflux causing the symptoms? Impedance monitoring can pick that up. Manometry, though, that's different. That's strictly reserved for evaluating primary motility disorders, think achalasia or esophageal spasm. Or it's required sometimes before anti-reflux surgery like fundoplication.
Right. Okay, so once we hopefully nail the etiology, the management has got to be precise. We can start maybe by just reinforcing those general supportive measures that, sometimes get forgotten in the rush of acute care.
Yeah, supportive care is foundational. Simple things like elevating the head of the bed to 30 degrees, that's essential for mitigating nocturnal symptoms just using gravity. We also counsel on behavioral changes, avoiding late meals close to bedtime. But again, probably our highest priority for structural prevention in the hospitalized patient is that preference for fine-bore nasogastric tubes over wide-bore ones for feeding.
Okay. Now, for reflux esophagitis specifically, the path seems pretty clear. PPIs are the absolute first-line pharmacologic therapy. The evidence is strong there.
Oh, it is. It's incredibly compelling. Pooled meta-analyses show PPIs offer an odds ratio of something like 4.2 for complete symptom relief compared to placebo. They are definitively superior to H2 receptor antagonists, which block histamine-mediated acid production, especially for healing erosive disease. H2 antagonists are largely relegated now to alternatives for maybe very mild disease, or perhaps as an add-on therapy for nocturnal acid breakthrough, or if PPIs are truly contraindicated.
And a critical point about actually giving the PPIs, and one where inpatient noncompliance or just incorrect timing often cripples how well they work, is the timing, isn't it?
Absolutely crucial. PPIs must be administered 30 to 60 minutes before a meal. This timing is essential because PPIs are actually inactive prodrugs. They need an acidic environment to get activated and bind to the active proton pumps. The peak number of active pumps happens after stimulation by eating food.
Ah, okay.
So if you give them at random times or with food, you significantly reduce the number of active pumps they can actually inhibit. You can reduce their effectiveness by like 30 to 50%.
Yeah, that much. Wow, okay.
Yeah. And for the most severe presentations, those Los Angeles grade C or D, we have to recognize that just healing it acutely is only the first step. The recommendation really shifts towards indefinite maintenance PPI therapy to prevent recurrence and complications. Or, alternatively, surgical intervention like fundoplication in very highly selected patients who have documented pathological reflux and maybe prefer an invasive solution over taking chronic meds.
Right. But we also have to pause for that safety caveat, the one about long-term PPI use. While they're indispensable for healing severe erosive disease, we do have a stewardship duty here. We really need to use the lowest effective dose and try to minimize long-term use because of those potential, though still somewhat debated, risks.
Things like increased susceptibility to enteric infections, maybe C. difficile.
Right, and potential micronutrient issues like B12 or magnesium deficiency, worth keeping in mind.
Definitely. Okay, so shifting gears to eosinophilic esophagitis management. The therapy here involves two main evidence-based pillars. The first one, maybe a bit counterintuitively, is actually high-dose PPIs.
Even for EOE.
Yeah, they play a dual role. They are effective initial therapy because beyond just suppressing acid, they also seem to modulate eosinophil recruitment and migration into the esophagus. And they also help restore the impaired epithelial barrier function, which is thought to be pretty critical in EOE pathology.
Interesting. Okay, so PPIs first. What's the second pillar?
The second pillar for patients with confirmed EOE who fail or only partially respond to PPIs is topical corticosteroids. This involves using swallowed fluticasone, typically from an inhaler, but you puff it into the mouth and swallow, don't inhale it, or using viscous budesonide. That viscous budesonide formulation is generally preferred now because studies show it has superior mucosal delivery.
Meaning it sticks around longer.
Exactly. The viscous prep prolongs the contact time between the steroid and the inflamed esophageal tissue. It maximizes the local anti-inflammatory effect while minimizing systemic absorption.
Makes sense. And what if chronic EOE or even severe G or D has led to mechanical problems like strictures?
Then we treat those directly. Endoscopic dilation is reserved for patients who present with persistent dysphagia caused by those strictures or fibrotic rings. We dilate the stricture, but we also have to remember to treat the underlying inflammation, whether it's EOE or reflux, to help prevent it from coming right back, restenosis.
Got it. Now let's quickly circle back and detail the specific management for infectious esophagitis. We talked diagnosis. How do we treat the actual bugs?
Okay. Candida is the most common, right? So we typically initiate systemic antifungal therapy. Often, that's oral fluconazole, maybe 200 to 400 milligrams daily for about 14 to 21 days. Topical agents usually aren't enough, given the severity. For HSV, it's often self-limited if the patient is immunocompetent. But in our vulnerable or critically ill patients, oral or even aciclovir or valacyclovir is standard. For CMV, which is often the most concerning, the treatment is systemic anciclovir, or its oral prodrug, valganciclovir. These target the viral DNA polymerase. And the duration of therapy for CMV is typically guided by repeat endoscopy we treat until we see documented endoscopic healing.
Okay. We also need to loop back to those special considerations for acid suppression in the hospital specifically. Prophylaxis. Stress ulcer prophylaxis, or SUP. What is it indicated?
SUP is indicated for specific high-risk patients, typically those with significant coagulopathy, patients on prolonged mechanical ventilation usually defined as over 48 hours, or patients in shock.
And when we do implement SUP, what's the standard?
Intravenous acid suppression is standard, either a PPI or an H2 blocker. However, it's really paramount to remember that the current evidence is clear. The superiority of IV PPIs over IV H2 blockers, specifically for stress ulcer prophylaxis, has not been definitively established.
Really? Despite common practice?
Yeah. Both are considered acceptable choices for SUP, although PPIs tend to dominate practice, probably due to convenience and their potent acid suppression capability. But for pure prophylaxis, the evidence for superiority isn't quite there.
Okay, but contrast that with acute GI bleeding, say from severe erosive esophagitis or ulcers.
That's different. In that acute scenario, especially after you've done endoscopic hemostasis, intravenous PPIs are definitely preferred. Giving a high-dose IV PPI bolus followed by a continuous infusion has robust evidence for stabilizing clot formation and significantly reducing the risk of rebleeding. That's a very specific mortality-driven indication where IV PPIs shine.
Got it. Okay, shifting now maybe to the grimmer side,
Yeah.
complications and prognosis. As you noted earlier, hospitalized patients with esophagitis generally do have a worse short-term prognosis, but it mostly reflects their high burden of underlying comorbidity, right? Not usually the inflammation itself being fatal.
Correct. It's a marker of how sick the patient is overall.
So let's detail some of the acute and potentially catastrophic complications we might actually encounter on the wards. Acute GI bleeding, you mentioned, that sounds frequent, particularly with severe, like Los Angeles grade C or D disease. And its presence is associated with increased inpatient mortality, forcing immediate action.
Absolutely. And then there's the truly catastrophic event, esophageal perforation. While it's rare, thankfully it might happen during endoscopy, either diagnostic or therapeutic, or sometimes due to severe infectious necrosis, like with CMV. It carries a really high mortality rate, reported somewhere between 13% and 30%.
Wow.
Yeah. Perforation is a surgical emergency. It leads rapidly to severe secondary infections. Think mediastinitis, empyema, abscess formation. If you even suspect it, say, the patient develops sudden severe chest pain, fever, maybe subcutaneous emphysema, you need immediate CT imaging, stat, followed by an urgent surgical consult. No delay.
Okay. And relatedly, you mentioned fistula formation.
Yeah, things like esophago-airway fistulas. You might see this with severe necrotizing infections, maybe severe Candida esophagitis in an advanced AIDS patient, for example. These are incredibly complex medically. The consequences of the fistula itself, basically allowing GI contents directly into the airway, they rapidly become the dominant medical crisis. It leads to severe, often really intractable aspiration pneumonia.
Which leads us directly to that broader category of thoracic complications. Aspiration pneumonia sounds like it would be frequent, particularly in patients with severe dysphagia or if they have a documented fistula. The presentation could be tricky, right? Might mimic typical hospital-acquired pneumonia.
Exactly. But the clinical context is key. If you see new infiltrates on the chest imaging, and it's coupled with known swallowing difficulty or suspicion of a fistula, that demands prompt initiation of antibiotics that specifically target oral flora. And you also need an immediate swallowing assessment, probably by speech therapy.
Okay. So for those cases that do heal acutely, we still need to counsel the patient about potential chronic issues when they leave the hospital. Strictures sound like a common chronic problem occurring in 7 to 23% of untreated or recurrent erosive cases. And these strictures are what drive that chronic dysphagia and food impaction later on.
Yeah, that's right. The good news here, though, is that management for these benign strictures is usually highly effective. Endoscopic dilation, often using Savory-Gilliard dilators passed over a guide wire, or sometimes balloon dilators, it resolves the stricture and improves symptoms in well over 80% of cases. The key, though, is ensuring they have appropriate post-dilation acid suppression maintenance therapy to prevent it from rapidly recurring.
Right. Treat the underlying cause, too. Okay, and the other major chronic complication we need to mention, of course, is Barrett's esophagus, that metaplastic change where the normal squamous lining gets replaced by specialized columnar epithelium. It develops in about 10–15% of patients with chronic reflux.
And while it is definitely a known precursor to esophageal adenocarcinoma, we should also emphasize that the absolute annual risk of progression to cancer is actually quite low, especially if there's no dysplasia present on biopsy. But that risk, however low, does necessitate indefinite surveillance endoscopy and usually maintenance therapy, typically with PPIs.
So overall, managing esophagitis in the hospital sounds like this delicate balance, doesn't it? Aggressive acute intervention when needed, but also really careful etiologic diagnosis. We can't just default to throwing PPIs at everyone without getting tissue confirmation if there are alarm symptoms or if the patient is immunocompromised.
Well said. It's about precision.
Okay, so that brings us nicely to our synthesis and maybe some final action items for the hospitalists listening. How can we apply these guidelines in practice, like tomorrow?
All right, action item 1. Don't rely on symptoms alone, seriously. If a patient has alarm features dysphagia, weight loss, bleeding, or if they're immunocompromised, they need an EGD with targeted biopsy and brushings. This is really non-negotiable for diagnosing those non-reflux causes like EOE and infectious types. And remember the details. The CMV diagnosis lives in the deep biopsy. The HSV might be best caught with the superficial brushing or NAT.
Got it. Action item 2.
Prioritize pharmacologic therapy based on the confirmed cause. PPIs are absolutely the gold standard for healing erosive disease, but remember that dual anti-inflammatory role they might play in EoE too. But for true confirmed EoE, the cornerstone therapy has to include those non-acid suppressing strategies, like the viscous topical corticosteroids, to really manage the eosinophilic inflammation itself.
Okay, and number 3.
And finally, action item 3 is all about proactive prevention within our own hospital environment. Control the controllable factors. We should mandate, or at least strongly prefer, using fine-bore nasogastric tubes for feeding to minimize that mechanical injury. And we should try to minimize prolonged supine positioning whenever it's clinically feasible, just to help gravity aid clearance.
Simple things, big impact. Okay, that brings us to our final provocative thought then, maybe for stewardship, kind of tying back to that safety caveat we discussed about long-term PPI use.
Yeah.
Given those potential risks with chronic administration, it really feels like it's the hospitalist's duty, doesn't it, to critically reassess the necessity of indefinite long-term PPI therapy before that patient walks out the door.
Absolutely. We initiate these medications so frequently, often for very appropriate acute indications or empirical trials. But we have to actively prevent what you might call acute care prescribing creep. We need to consciously ask ourselves at discharge, does this patient really need indefinite maintenance based on, say, documented Los Angeles grade C or D findings or severe Barrett's? If they were just treated empirically, or if they had non-erosive disease that healed, we must critically apply that guideline. Use the lowest effective dose for the shortest duration possible. And ideally, document a clear plan for attempting deprescribing after that acute healing phase is complete.
That really is the core of good hospital medicine, isn't it? Making sure our acute care solutions don't inadvertently create chronic problems down the line. Well, thank you for diving into all this evidence with us today on Hospital Medicine Unplugged.